Good morning, my name's James Danger, and this video I'm looking at the rise in progesterone prior to the ovulation trigger and the causes and effects of such rise. The video was prompted by this paper appearing on my publication list, not because when it was published, which is in 2024, but some editorial expression of concern just published last week that whether this was a fully retrospective study. I don't think it takes much away from the article itself, but prompted me to go back and look at the rising progesterone levels as a topic that all clients and staff should be aware of. And I think in looking at this data, I'm actually giving some good points, which I'll summarize right at the very end of this video. So there was that paper, plus this is the second one, also in 2024, that looked at the relationship between serum progesterone levels and AF-HCG and the outcome. Okay, so like always, this IVF Daily channel is looking at trying to summarize all the thousands of articles that appear each year in IVF. Look at this one in 2025, up 2,500 articles on IVF. Some are very long-standing, some like PGT-A are more common. But if you look at the publications looking at elevated progesterone in IVF, there's about 400 odd papers, but the majority of those have been in the last 10 years, but fairly steady numbers over that time. And before I go on, I just need to make you aware that I do have a promotion notice board, where if you're a clinic or a company providing services to IVF clinic or anything to do with patient management, which I like to support, if you'd like to post a notice of your website on the, I'm more than happy to do it for a small fee, of course. Okay, let's get back to the topic at hand. So this paper, the relationship between serum progesterone levels and oocyte maturation, was the thing that started the toss. I'll start here, but I can tell I'm going to end up in quite a different place. And I think it's worthwhile surviving to the end. Surviving is the right word, to see where this goes, because it's all got to do with the stimulation method. So at the time, people weren't really interested in that, but in reality, it's all got to do with the stimulation of FSH and LH. So this paper just looked at the 200 odd couples, looked at this progesterone level on the day of HCG, and put them in order the rising HCG. The reason I did this was you can see that the vast majority of people have very, very low levels of HCG, around about 1 to 2 nanograms per mil. And it's only in the last 10, 15% does it rise, and only the last 5% does it get really, really high. And what they did was they took each progesterone level and looked at the mean number of eggs that had polar body above and below the line. And you can see that as progesterone starts to rise, the people below the line, which is the blue one, you can see is fairly steady, roughly about 1.2 oocytes. It doesn't sound very much, does it? But you can see here, people above the line, as the line gets higher, there's fewer and fewer of them, but increasingly you can see that there are fewer and fewer eggs being collected. So this paper was suggesting that for each case, the mean number of mature oocytes were calculated above and below the progesterone level, and at progesterones of about 1.54 nanograms per mil, the number of mature oocytes in the elevated group started to decrease. And indeed, this figure of about 1.5 nanograms per mil progesterone seems to be the cutoff point for triggers for clinicians to make decisions about whether the embryo should be transferred or frozen. But this paper was suggesting there were slightly fewer mature eggs. But they also made the point, if I just want to go back, I know, that this was unrelated to the age of the woman or the BMI of the patient. So these are something to do with the follicle recruitment and not anything to do with patient age, etc. I have to say, when I read this, I thought, I'll just do the plug. This is a paper that I wrote back in 2085. I just did an IVF, and in the first 59 cases we did, of which we had 10 pregnancy, I have to say I was quite impressed. 984, a 20% pregnancy rate, I was chuffed. But of those, I could already notice in those first 59 cases that there were some with an elevated LH and progesterone, and that there were no pregnancies in that group. And so I had surmised at that point, somewhat incorrectly, may I point out, but I was young and full of energy. Reduced enthusiasm, no, reduced fertilization may be a reflection of premature oocyte aging, or maturation, and this might have clinical implication in the management of some patients with unexplained infertility. But what I really was talking about here was PCOS. But this is the first publication, 1985, IVF had been only going a couple of years, where already a rising LH and rising progesterone was bad news for women having IVF. And it took another 40 years for people to catch up with these observations. So the background, an elevated progesterone before the ovulation trigger may represent PCO couples, but in such cases, the LH is elevated during the whole stimulation process. But modern IVF systems suppress the LH, and I'm going to come back to it right at the end because this is important. However, in about 5% of cases, the normal serum progesterone concentrations start to rise at increasingly critical levels that suggest one or more follicles are starting to precociously luteinize. This is what I was thinking, and I'm going to show at the end that this is actually not true. But does this affect the oocyte or the embryos? And I think this is an important question. And does this affect the endometrium? This is the question. Okay, let's look on. So just very quickly, as you know, in a follicle contains the oocyte and then an inner layer of cells called the granulosa cells, an outer layer called the theca cells, and there's a barrier between this. There's a membrane between these separating the theca and granulosa cells that only breaks down after ovulation. The studies indicate that serum progesterone elevation during follicular phase is not always prevented by LH suppression, which is seen in up to 30% of cases. Now, we actually now understand why. Many hypotheses have been considered to explain this phenomenon, like the two-cell gonadotrophin theory in the biosynthesis of estrogen, where it says the granulosa cells, by means of FSH, contribute to the conversion of cholesterol from progesterone, which is converted to androgens under the influence of LH in thecal cells. And the two-cell theory layer goes that the cells on the outside, the thecal cells, take cholesterol, convert it to androgens, the androstenedione, which then can pass this this layer. It's not a membrane, it's an acellular layer between the theca and the granulosa cells. It's a bit like the barrier of testis, it's the same thing, where the androstenedione is converted to estrogen, but excess levels can be converted to progesterone. So these androgens are then passed to the granulosa cells to produce estrogens in controlled ovarian hub stimulation cycles due to the increased number of follicles with 17 millimeters or possible LH effects from exogenous gonadotrophin. Granulosa cell sensitivity to FSH is increased. I'm going a bit faster, I might slow down. The rising estradiol levels may induce an increased LH secretion sufficient to stimulate thecal and granulosa cells to produce progesterone, but inadequate to trigger ovulation. I think I should do a talk sometime in the future about how ovulation is triggered in natural cycles, because I think there's a lot there that we actually just are ignoring. Studies have shown beyond the optimal standard follicle maturation, the duration of controlled ovarian hyperstimulation should not be prolonged. And just to make matters worse, I'm probably already nodding off. I just wanted to make the point here. This is looking at the follicles from growing to pre-ovulatory, the dominant follicles, and then what happens after ovulation, where the follicle becomes fully luteinized in the corpus luteum. And this is where the damage is being done. So in the tertiary follicle before ovulation, theca cells produce cholesterol to androstenedione, diffuses through the cell layer, and is converted into estradiol and also progesterone, which goes back into the blood supply. But in the pre-ovulatory follicle, immediately before ovulation, and in the corpus luteum, all the cell layers are broken down to form a new cell layer, an amorphous one called the luteal cells, which are largely coming from the granulosa cells. And their primary role is produce progesterone and some estradiol. And the reason for that is all to do with the rise and maturation of the endometrial layer. So here's the rise in LH, and by the time the LH falls, progesterone is just starting to rise just a little bit. And what we're talking about here is this rise in progesterone starting to rise up here before the LH surge. Can I also make one last point? I've done a couple of videos just recently on sperm maturation in the oviduct, and this surge in progesterone at ovulation, so the egg is being released, but all the follicular fluid is also being released into the oviduct. And there's that rise in progesterone in the oviduct, which is the trigger for sperm capacitation. So those other videos, I think that's actually a really important issue. So just to summarize this, and I'm going to leave it, I've already probably lost half my audience. These the granulosa cells synthesize progesterone during the follicular phase and increase production significantly as they mature and undergo luteinization. So you can see why a rise in progesterone would be considered precocious luteinization, but this is wrong, theoretically. Thecal cells, these outer cells also produce enzymic capacity to produce progesterone and can secrete progesterone directly, particularly in large preovulatory follicles. While both cell types contribute to steroidogenesis and make progesterone, its granulosa cells are traditionally emphasized as the primary follicular source for producing progesterone that transitions to high output after luteinization. Okay, so that's a long preamble. I'm probably taken so long. Let's get back to this paper. Does this rise in progesterone affect the embryo quality? So, what they took 58 patients with an elevated progesterone and found 58 patients that were matched to them using some particular software. So it's a control group. And what they show was elevated progesterone levels exceeding 1.5 nanograms per ml on the trigger day were directly associated with a significantly larger number of antral follicles, subsequently leading to a higher count of retrieved eggs, mature eggs, successfully fertilized eggs, and embryos reaching the blastocyst stage. Furthermore, the analysis of morphokinetic parameters indicated faster division times and a notably greater number of high-grade blastocysts in the study group compared to the control group. So that's the Philippines. So what they're saying is that even though we might think the elevated progesterone is bad, when you look at the embryos, the opposite is true, that in fact a rise in progesterone is maybe an indication of better embryo quality. So in the study group, this group, they had more eggs, more mature eggs, more fertilized eggs, and more blastocysts per egg. So I mean, all those were significant. And the conclusion was in all four parameters assessed show statistically significant differences between the two groups. In detail, the study group displayed a higher number of oocytes retrieved, more mature oocytes and fertilized eggs, and obtained more blastocysts from the control group. So you can see why they made this is a quite an important claim, and you can see why maybe the editors of the journal have gone back and queried this just a little bit. But I think the data holds up reasonably well and just need to take it on face value. But importantly, if you look at the time lapse data, I'll only really worry about the blastocyst. The other one I think is the diversion. You can see here there's a significant difference between the study and control group were highly significant only in the early stages. But you can see here that embryos deriving from cases with an elevated overall serum progesterone, so this is an elevated serum progesterone, reach these milestones, polar body breakdown, pronuclear breakdown, two-cell division, four-cell division, moral and blastocyst. The blastocyst not so much, even though it was a little bit faster, but it was the early ones where all the early cell division occurred far quicker. And interestingly enough, I went back and looked at the blastocysts. You can see, even though there's not a lot of cases here, there is this tendency towards having blastocysts which are more expanded from high levels of progesterone. Not so much the ICM, although in this group there were more embryos with a very poor inner cell mass. So they may have been well expanded blastocysts, but the inner cell mass was poor. And the trophectoderm, even though it wasn't significant, 0.8 and 0.7, really does tell you that, in fact, there's a difference. Although when you look at it, it's kind of confusing what that means. So there is this suggestion that from blastocysts coming from a group that have an elevated progesterone, is the blastocyst does seem to be expanding more. It does seem to be affecting the trophectoderm more than inner mass, but this data is actually quite confusing, and you don't want to take too much from it. It's just, I thought, interesting to look at. So in conclusion, the author said progesterone levels exceeding or equal to 1.5 nanograms per ml on the day of HCG trigger may be correlated with a high number of antral follicles observed and consequently with a high number retrieved, mature, properly fertilized, and those reaching the blastocyst stage. So contrary to the hypothesis in other studies, premature progesterone rise not only fails to alter morphokinetic development, but appears to enhance the trajectory with faster development and timelines observed during the initial phases of embryo development using the time-lapse systems that may positively influence embryo competency. Okay. However, based on the larger number of evaluated patients and obtained data, it could confidently be stated that premature progesterone rise on the day of HCG trigger did not negatively impact the competency of retrieved oocytes or embryo development to the blastocyst stage. However, elevated progesterone levels on the trigger day could lead to premature endometrial maturation and consequently asynchronization of the endometrium and embryos on day of transfer. This should be prevented by choosing a frozen embryo transfer. Okay. If you go back and look at, we're shifting, basically what we've shown here is that elevated progesterone rise is not detrimental to embryo quality, but it sure is have an impact on transfer of live embryos from a fresh transfer. And quite clearly, there's been a lot of studies, there's one in 2023 recently, clearly showing that as progesterone level rises, there is almost a linear fall in progesterone, fall in predicted live birth. So it's not like a drop off where it's flat and that falls off. There is this slow, insidious decrease in the likelihood of pregnancy as the progesterone on the day of HCG starts to rise. So having an elevated serum progesterone on the day of HCG trigger was associated with a lower pregnancy rates, but this is still not a robust marker to predict live pregnancies. More good quality evidence is needed. And I think that's just incredible, the incredible variability of the implantation window, which in fact, we used to be really a hot topic 20 years ago, but it's gone off the boil, but I think it needs to come back. But if you look at this paper, the effect of progesterone concentration at HCG trigger on clinical outcomes between fresh and frozen, you can see that with the frozen cycles, the blue line, right, the pregnancy rate is kind of flat. That is, it's nothing to do with the embryos. It's actually all good to do with the transfer of embryos in a life cycle, that is the endometrium. But interestingly enough, this line doesn't increase. I've noticed that in this study, the pregnancy rate from is actually almost falling just a little bit, but not a great deal. So the authors concluded when progesterone levels on HCG trigger day were between 1 and 2 nanograms per mil, the clinical pregnancy rate for frozen thawed cycles of high quality single blastocyst transfers using a GnRH antagonist protocol, that is zero endogenous LH, significantly surpasses that of fresh transfers. Thus, elective frozen embryo transfers, that's freeze-all strategy, is recommended. And if you go back and look at a really interesting study, this was published last year, February 2025, looking at the ploidy rate. So I asked the question, does progesterone rise prior to affect the euploidy rate? And this data, looking at donor eggs, clearly shows that it does not. So this study looking at the effect of progesterone levels on the day of trigger on embryo ploidy and egg donor cycles. Egg donor cycles are proven to be a really powerful tool in understanding what's happening. Basically, they could look at, this is the egg donor cycle. This is ones where you had very low progesterone and low antral count plus high progesterone and high follicle numbers. Interesting that they grouped it like that, but basically you show no difference at all. So it's not quite the same as a previous study. But in this case, a high or low progesterone produced the same outcome in terms of the number of eggs recovered, the number of mature eggs, and the egg maturation rate. But interestingly enough, you go back and look when those embryos were transferred into recipients, right? Also, there was zero difference. That is the critical one. This is the euploidy rate. So the euploidy rate was exactly the same, and the clinical pregnancy rate was exactly the same. So even though these in live birth, the pregnancy rate will fall really quite precipitously as progesterone rises, it does not affect the embryo quality. However, in this point, the authors are making the point that it's actually not making it better. It's basically not affecting it at all. But so I went to ask the question, well, is this due to individual follicles luteinizing or not. And so basically looking at a couple of people looked at progesterone levels in individual follicles, and these are 3 papers that I found. The first one, this study evaluated individual aspirated follicles from single follicles and found that progesterone, along with AMH levels in follicular fluid, were significantly higher in follicles that successfully yield blastocysts compared to those that only achieved early fertilization. The second one, that was in 2018. The first one was 2019, and the third one was 2018. So these are all 4 or 5, 6 years old. The second one, a systematic review, a meta-analysis published in RBM Online, analyzed over 1,000 individual aspirated follicles and demonstrated that intrafollicular progesterone concentrations were roughly 30 to 35% higher in oocytes that contain normal fertilizing than those that had failed fertilization. And this one, I'm not really quite sure whether this is relevant or not, but I included it anyway. Investigations utilizing mass spectrometry on individual follicular microenvironments note that higher local progesterone profiles alter neighboring steroidogenesis and metabolic signatures, such as local estrogen estradiol balances, which can reflect individual oocyte quality. And in fact, this is a funny paper, and a lot of Chinese papers are quite quirky, but they provide a really different insight. This one is suggesting that one follicle, which may have a really high progesterone, has the capacity to influence the microenvironment of adjacent follicles. So they're not all, or not all these follicles are acting independent. There is a very strong synergy acting between them. And in this one, and looking at AMH levels, progesterone levels, this was in 2019. They looked at the progesterone level in terms of whether the embryo was a blastocyst or not, and consistent with all the previous data, that the ability of an embryo to form a blastocyst seems to be high if it's come from a follicle with a high level of progesterone. That is indicating these follicles are really mature. The study indexed via PubMed evaluated individual aspirated follicles from single follicles and found that progesterone, along with anti-Müllerian hormone levels in follicular fluid, were significantly higher in follicles that successfully yield blastocysts compared to those that only achieved early fertilization. You know, when you think about this, this is a bit of stuff which is really important for embryologists to take note of. That is, when you are looking at blastulation rates and all this sort of stuff, and you're looking at A and B and C, you now have to take into account whether the progesterone levels on the day were rising or not, but also be aware that there's a lot of variation between follicles, and the follicles that are more mature are more likely to deliver an embryo that forms a blastocyst. So the levels in progesterone follicular fluid, the scatter plots represent the follicular fluid progesterone levels in group A, this one here, blastocyst, follicles containing developed blastocyst by day 5. And group 2 were the follicles containing oocytes that fertilized but failed to reach blastocyst stage. This fertilized, but they arrested. So even though you can still get blastocysts from follicles with very low progesterone, the trend there is the higher the progesterone, the more likely they are to continue to develop. But just to throw, I'm getting close to the end now, but I thought I'd just throw in a couple of quirky papers. One was 2019. They looked at, amazing what people study. You know, you do have to be impressed with people's curiosity. These people looked at the serum levels in the morning. So the people had the injection, the last FSH injection at night. So this is 12 hours later. Then they looked for whatever reason progesterone levels during the day. And they could show that during the day, progesterone levels fell quite a lot. So by the time they got back to the time of the trigger, you can see the progesterone levels are high. So if you measure your progesterone 8 o'clock in the morning, it's already falling from the previous night. So presumably, like at 2 o'clock in the morning, it will still be higher again, right? But it will fall. And so, in other words, progesterone isn't this constant level. There's this pulse. Having an injection, there's a rise in progesterone that falls, rise in progesterone and falls. And I think in many ways, what we're talking about here is when it falls, whether it accumulates back to almost a lower level, or whether it attenuates and starts to rise. And no one's looked at that yet, but I suspect that's what's happening. I've done that with something else. So conclusion, The study finding have two clinically important conclusions. One, the progesterone levels on the day of the final oocyte maturation decline significantly from the morning to the afternoon, presumably from the evening to the morning, questioning the reliability of one arbitrary taken progesterone levels regarding the decision to perform a fresh transfer or a frozen one. Okay, so I think this needs a little bit more time, maybe another video. But if you're going to use a progesterone of 1.5 as a cutoff to defer transfer, only do frozen transfers, you need to recognize exactly what's happening. And I think that if you then have to actually what it's really doing is actually making you go back and ask the question, when was the injection done and when was the blood test done? So people that have very low levels, you don't need to worry about. But when the progesterone levels are rising, you need to, theoretically, you need to ask the patient when they did the injection, then look at when the blood test was collected, because it could well be that in some cases do have an elevated, but if the blood test is taken lunchtime or so, if they're the last patient coming through in the list, there could actually be more that are being missed. In other words, there are some people that should have an embryo transfer being deferred, but because the blood test was collected late in the morning, then in fact they're scraping through. The second point is that declining progesterone levels 12 hours after last administration of gonadotrophins support the theory that enhanced ovarian stimulation at the end of the follicular phase leads to an overload of the capacity of enzymes metabolizing progesterone further on, resulting in an elevated levels in circulation. This is what I would call attenuation, where there's so many follicles, they can't get it back to those levels, so it starts to build and build and build. And almost lastly, I found this paper in 2018. Actually, this is when most of the work was being done. You look at the rise at the fall in pregnancy rate as rise in progesterone levels, and implantation rates, live birth rate between cleavage and blastocyst. That's the same, although it seems to be worse with progesterone. Sorry, for blastocysts, and it may be because the implantation window, the embryo is going back in right at the middle of the implantation window, whereas cleavage stage embryos just might have some impact on modifying that window. But if you go back and look at the number of oocytes, you can see that these are ones, the case of the implantation rates, live birth, they're much the same. That the very low levels of follicles, there's only a small impact, but the impact gets higher as you have more and more follicles. So the more follicles you have, the greater the impact. In other words, if someone has an elevated progesterone and they only have 2 or 3 eggs, you may still consider to do the fresh transfer because the change in pregnancy rate is very low. But if you have 15 or more oocytes and the rise of progesterone, then that is a marker to defer the transfer. And also good and bad embryos. I'm not really quite sure. I haven't really quite got my head around this one. But the trend is also the same. That is really good quality embryos. The impact is really severe, and poor quality embryos not so severe. And I don't really quite understand that, except look at here. This I think is important. This tells you that there is some cutoff here. That is, so really good quality embryos, you put them back on day 5. These embryos are almost within 12 hours, putting that embryo, it will have hatched and starting to implant. So the implantation window has to be open and be receptive sufficiently long to allow the implantation process to become established and HCG to produce by the pregnancy and to halt regression. And it looks to me like I think this needs to be confirmed. I'm not really quite sure how true this is, but it does look like if you have really, really low progesterone and a really, really good quality embryo, so good quality blastocyst, the rates can be at 75%. So some of these rates you see where you're putting back really good quality blastocysts in like 65, 70%. This data is suggesting that those cycles have almost no progesterone. That is, the window is still open and the implantation is only ever starts at the trigger and there's no precocious movement. But if you look at it, you can see once you get this critical point 1.5, right, suddenly it's disaster. So if you have a really good quality blastocyst, and you have a proj of more than 1.5, if you put that embryo back, it's just wasted embryo. Okay, Without an LH surge and luteinization, the cause, actually, this is the end point of this talk, and I hope you've waited, because if you haven't, you've missed out on the important thing to really understand exactly what's happening. Without an LH surge and luteinization, the cause of modern premature progesterone elevation is putatively not premature luteinization. However, studies as recently as 2015 still refer to premature progesterone elevation as a historic misnomer of premature luteinization, and I think I'm probably guilty of that. Since 2010, studies have demonstrated the cause of premature progesterone elevation to be primarily due to an excess number of follicles present. Each of the follicles contribute a small amount of progesterone production as an intermediate in the steroid pathway. With a few follicles, this is a minute contribution. However, with many follicles, the total level of progesterone increases to clinically relevant amounts. And I think this is a good part. I think Michael Evans has actually got it spot on. The association of follicle number with progesterone has been documented in numerous large studies. Furthermore, FSH-only protocols and total FSH dose increases the risk of premature progesterone elevation. Conversely, the addition of LH protocols decreases the risk of premature elevation. This is due to the fact that additional LH upregulates 17-hydroxylase to convert progesterone substrates to androgens, which are ultimately aromatized to estradiol. Taken together, these data support that the common cause of premature progesterone elevation in GnRH analog cycles is not the result of LH-induced luteinization, which I said back in 1985. I was wrong, but rather a product of FSH-induced progesterone stimulation from a large number of follicles. And just to prove the point, this paper came out about a week ago from Chinese authors, making the point that the association between late follicular progesterone elevation and reproductive outcome differs across ovarian stimulation protocols, demonstrating a non-linear relationship in both clinical pregnancy rate and live births. These results suggest that the late follicular progesterone elevation should be interpreted with protocol-specific considerations. And it's all about to do with whether you have any LH or not, and ones that really suppress pituitary secretion. So there's zero LH, and you have a lot of follicles. If you have that case, you are asking to have all those follicles frozen and the transfer to be deferred. And maybe in future cycles, it may be worth changing the protocol to allow some LH to occur, which will actually cause that progesterone to be modified and then have a fresh transfer where the pregnancy rate is at least or better than the frozen ones. Okay, so overall, elevated progesterone in individual follicles appears to be beneficial for oocyte and embryo development. The progesterone in individual follicles is highly variable, but is not the defining quality that predicts blastocystic development. A slightly raised serum progesterone may imply the follicles are reaching maturity and potentially stimulate natural ovulation and other factors. The sum of all follicles at the time of HCG can be stable and low, but may slowly rise as follicles mature. And the more follicles there are, the faster it will rise in the absence of LH. A rising progesterone may cause follicles to yield more mature oocytes and generate embryos that develop faster. But elevated progesterone levels at ovulation induction will reduce the likelihood of pregnancy in a fresh embryo transfers. Pregnancy rates in FET cycles are not impacted by the rise in progesterone during collection. Therefore, it may be good clinical practice for a clinic to develop rules for freeze-all the embryos when the serum progesterone at trigger is elevated. So a clinic needs to have a rule somewhere, and my guess is that it goes something like this. If you have a rise in progesterone and a large number of good quality embryos, you should freeze them all. The fewer the embryos you have and the slower the progesterone rise, the more likely you could probably get away with a fresh transfer. That'd be my guess. So just to finish up, thank you for persevered for so long. I commend you. My name's James Stanger. I'm a PhD with an embryologist with more than 50 years experience in IVF. I'm not a medical person, and this information is not medical advice, but it may help you in knowing what questions to ask about your treatment with your doctor and maybe help in understanding the advice you receive. If you like what I'm doing, press subscribe, become a member, tick what you like, and please make a comment. But more importantly, tell all your other cohort and friends in your clinic and embryology group to keep visiting my website. I do like to recognise that this is being funded by my other website with fertility.com, which is an online EQA and training program in IVF and embryology. I'd like to thank you for persevering if you lasted this long. I know IVF is a personal journey that involves the action of many techniques, people, and ideas. It helps to understand all aspects where possible. And at this point in time, I would like to say thank you for listening, and goodbye.